Good morning. If people could please take their seats, we'll get started in just a moment. Tara, we're taping this, right? All right, so just know that you're on film, so don't do anything embarrassing. So good morning. I'd like to welcome everyone. This is our fourth reporting out from the, Delivery System Reform and Innovation Payment Program Performing Provider System Report Out. That's a mouthful. We've mixed things up a little bit this year. In addition to having the PPSs and the Chief Medical Officers report out, we're having some of their partners, so community-based mental health and primary care partners report out as well. So it's a new format, hopefully a little bit more interactive, and we hope you like it. Since it is interactive, please, on your tables, you should have cards for questions. So if you have questions, please write those down. They pop up. At some point, we'll ask you to hold those up, and we'll come around and collect those and make this hopefully as interactive as possible. My name is John Craig. I'm the Executive Director of the Population Health Collaborative, formerly the P2 Collaborative. Please grab a pen. I think that's what we're getting known for now as much as anything. People rave about our pens. So grab the pen and spread the word that we've changed our name, and we're always looking for partners as well. So welcome. I'd like to thank Millennium Collaborative Care PPS and Community Partners of Western New York PPS for joining us. Thanks as always for any event that the Population Health Collaborative runs to Tara Maving and Christina Chenault, they're out there someplace who do all the legwork, and the committee that put this event together. So we're delighted to have you. At this point, I guess we're just going to, real quick question first of all, by show of hands, how many people here are with a healthcare professional or a healthcare professional organization? Just put them up high so we can get a sense. All right, terrific. About half. How many of you are with a community-based organization? Oh, so we're about half and half. That's a good split. Terrific. Okay. All right, so at this point, I'm going to have Amy White-Storfer, the CEO or Executive Director of Community Partners of Western New York, and Al Hammonds. Al, where are you? There you go. Al Hammonds, Executive Director of Millennium Collaborative Care, give some brief overviews, and then you can see in the agenda we're going to shift into some mental health and then a panel discussion later. So I'll turn it over to Al and Amy. Thanks.
Good morning, everyone. Good to see you guys. We're going to continue the tradition since DISRIP started of giving you guys these regular report outs. I'm going to start off kind of giving you a high-level overview. We're going to kind of tag team, Amy and I, and then we'll have our other presentations. So this is kind of like the layout for today in terms of who's presenting, and it's been I just want to take a couple of seconds just let the community know. I think you guys know, those of you who are working with both of our PPSs, that we are working hand in glove, extremely close, even though we're two separate entities, because patients and Medicaid beneficiaries in our region, they don't know the difference between CPWNY and MCC. We have to work seamlessly to make sure that we're providing the right transformation in terms of their care. So this is the agenda. As I said, we're going to do some high-level overviews. Then Andrea and Phyllis are going to speak, and then we're going to have our roundtable of various folks representing key partners within our PPSs to open it up and have some good question and answer dialogue. So starting off in terms of our regional collaboration, just to give everybody perspective, is when we look at the number of lives that both of our systems are trying to impact, it's approximately really close to 350,000 total Medicaid lives attributed to both Millennium Collaborative Care and Community Partners of Western New York. About a little over a quarter, sometimes it's closer to a third of the entire Western New York population do receive some form of Medicaid benefits. 260,000 of those 345,000 lives approximately attributed to Millennium in those counties, and then the 85,000 are attributed to community partners. When we look at, what we're getting ready to look at is performance, what we call, we have DISRIP years, and then we have measurement years, almost like regular years and dog years, right? So anyway, in DISRIP, in measurement years, when you look at the period of July of 2015, which is literally just after DSRIP started, until June 30th of 2016, that was actually what was considered measurement year 2. So when you look at performance across the state, across the 25 PPSs for that period of time, which is really the first real data that we're seeing related to since the community needs assessments were done in late 2014, early 2015, the regions, the performance really is by region. Like for example, in our western region, you see kind of the PPSs that the state considers the western region versus central versus the New York City. Areas where our western region did well was in potentially preventable readmissions to hospital. Our region also did well in a lot of the behavioral health metrics as a region, and a lot of the pediatric and those type of measures as well. Where our region struggled was in the potentially preventable ED visits. And then in the New York City region, they did a little bit better in the potentially preventable ED visits, but didn't do as well in the potentially preventable readmission. So when you look at the various metrics that we were measured on at that time, it's very regionalized in terms of how the state performed. We're going to give you an overall view, and then Amy and I will give you PPS by PPS view on the performance, but need to understand the geography of performance as well. So when we look at what's going on here, like you say, in the left-hand column, you can see the DSRIP years, which is what we've been primarily focused on, and then you can see the measurement years, and it's just the difference of what's going on. So we're midway through, as we stand here today, midway through DSRIP year 3, but also heavily into measurement year 4. So the stuff and the activities and the initiatives and the efforts that we're working on right now, actually we won't know the results of measurement year 4 until actually 2019, the summer of 2019, because next year, in July of 2018, we will find out from the state how we did for measurement year 3, which ended this summer. So it's a little bit off, if you will. And you can see that the measurement year 2 stuff, which is what we're primarily reporting on today, you can see when both myself and Amy started, you know, either I had just started or Amy wasn't even on board yet when the measurements actually started for measurement year 2. So looking at the statewide measures and measurement year 2 and how we actually did, you can see that overall our primary objective in DSRIP is to look at and promote the community level collaborations that we need to make that 25% reduction over 5 years in avoidable hospital use. Also, you can see here how the state is doing, which is actually well. The state is on track overall in terms of what they anticipate with DSRIP in terms of potentially preventable readmissions, ED visits, adult avoidable admissions based on the prevention quality indicators, PQIs, and then the pediatric avoidable admissions. You can see how the state's doing overall. And the state as a whole is on track to see a reduction to achieve over about 27%, which is higher than the target. For us, looking at how we did measurement year 2, you can see the actual key measures in the left-hand column, what they actually are, and the projects and measures wasn't that going from left to right. The ones that I want to highlight is in the avoidable hospital use. When you can look at how we did, the state had like these 4 different tiers of how they tiered all 25 PPSs, and we were in that second highest tier in terms of performance, which was very well in terms of all the PPSs along potentially preventable readmissions. We also did well on PQI, and we're improving in measurement year 3, which is over now, but we're looking at measurement year 3 data right now. We exceeded the statewide targets around avoidable pediatric admissions, skipping down into the behavioral health. You guys can read the slide on your own, but In the behavioral health metrics, the antidepressant medication management, the diabetic screening for people with schizophrenia, we've done extremely well there as a PPS, as well as in the primary care arena as well, in terms of the rest of the state, in terms of measurement year 2, once again, looking in the rearview mirror. Overall, there is a total of 54 what we consider pay-for-performance measures, as we've shifted gears from the first 2 years of DSRIP into the final, in the final 3 years. Everything's about outcomes, less about patient engagement and reporting, more about the bottom line outcomes, and you can see how we did. So I'll turn it over to Amy for her portion.
Hi, it's great to see everybody today. One thing I wanted to just sort of punctuate what that Al just said was the people might say today, we're hearing out really good detail about the behavioral health integration projects and primary care integration projects, but we're not hearing about the other projects today. We'll be happy to take questions about those projects, but I think what Al was talking about when he said we're moving into this health outcomes focus, projects are really critical. Many of them touch the health outcomes, but we're also working with our partners to say what other things can we do to really try to put laser-like focus on key sets of our health outcomes. And that's going to be a reoccurring theme that you're going to hear throughout the rest of the morning today. And we really want you to ask questions about those things, because there's a lot that you think about. New York State's asking us to look at approximately 71 health outcomes. That's a lot to think about, and it's a lot of stakeholders to listen to and to talk about the different ways that we hit those health outcomes. So your feedback on how we're doing and your ideas are really going to be important to continue this work through the end of the DSRIP program. So we've hit very similar metrics to Millennium, which again I think punctuates what Al was saying around a regional approach, and that these are really regional metrics. We did have, again, really excellent high performance on the preventable readmissions, but we did not hit our target for both the avoidable admissions, and which is the complications composite measure, and the ER visits. So we are moving in the right direction, but to close a gap that New York State Department of Health set for us, we did not close that gap, so we can do more work in that way. We also continue to do very well on the primary care access metrics. That doesn't surprise anyone when you look at, for our PPS, we're working with 2 established physician networks, those folks who are in the Chautauqua County Integrated Delivery System, as well as the organizations who are part of the Catholic Medical Partners. So that I'm sure that doesn't surprise anyone when there's primary care access, because they've been working on primary care access inside those networks for a really long time. Behavioral health, this is a shared success story with Millennium. It's a shared success story with our behavioral health partners who have had some real strategic application of funds to hit some of these metrics, but also their ongoing work to sort of look at what is the low-hanging fruit, who are the folks we can touch that really can try to connect with better medication management and different kinds of medical screenings for folks with behavioral health diagnoses. And I'll call out that we were 5th of 25 PPSs in the diabetes monitoring for people with diabetes and schizophrenia, but again, that's very much a shared success story with Millennium. And you're going to hear a lot more about that when our behavioral health team comes up and talks about that. Phyllis and Andrea are going to drill into exactly why the work that they're doing there. And then on the maternal and child health, again, great partners here with both of our folks who are doing OBGYN access, but also that we have some great programs across the region with community health workers, and I think this tells that story as well. So this, again, punctuates what Al was saying. It really underlines that, which is we're moving, this red bars are becoming more and more important, meaning we're moving away from sort of, hey, do you have a project team? Tell us who's on the project team. Hi, do you have a process flow describing the changes you're doing in the clinics or in the community? Those are reporting metrics that are represented by these blue bars at which we can get reporting payments for. But as we move into DY3, 4, and 5, that red bar becomes more and more important. So those dollars are really tied to these health outcomes metrics. So you do see that shift. And the reason we put this slide up there is to sort of explain to you, like, yes, we love our projects. We want to keep working on those projects, but we may be tweaking those projects to even have a more laser-like focus on the health outcomes. And if people have questions about this, we're happy to take it. But it's something I know that Al and I, when we take our road shows out and we talk about how DSRIP's changing over its life cycle, this is the thing that really shows that and demonstrates why we're sort of shifting gears a little bit. And I think it is just a shift, because many of our projects do try to address these health outcomes. So I'm going to hand it back over to Al to drill a little bit more into what the work he's doing, and then I'll come back and introduce the rest of the folks.
Thanks, Amy. Let's take a deeper dive into where we stand as a Millennium. So once again, taking a deeper dive into the population that we're focusing on, the 260,000 lives that are part of our attributed lives by the state. You can see kind of the population and how it spreads throughout Western New York and even overall as a state. And then you can see statistically, you can see in terms of the number of the percentage of the Medicaid population that we're trying to address. The big thing that jumps off is the 28% of our attributed lives. And this data is a little, once again, we're looking in the rearview mirror at measurement year 2 type information, which covers July of 2015 through June 30th of 2016. That's the reference point for this data. And at that point, 28% had no claims for primary care, 24% did not have an assigned PCP, only 6% were enrolled in a health home. And as you guys know, health homes are extremely critical in terms of reaching folks with multiple diagnoses to get the help that they need. For the first two, now shifting back to DSRIP years, which is how we were, I know, back and forth, DSRIP years, which is looking at April of 2015 up through March 30th of this year was the first 2 years of DSRIP. You can see funding-wise where our big focus was as a PPS. You can see that the bottom half of this table is DSRIP year 1, where we earn 98% of our dollars, really heavily focused on the projects, the work streams, the reporting, all of the things that the state was really driving performance on based on that year. And then 95% of our funding was earned on the top part of the table for DSRIP year 2. The very top part of the graph, which is the gold, is where we've just started to begin to get measured. That's the measurement year 2 stuff, which you're hearing mostly about today, which is what we consider from our budgeting purposes and funding purposes non-core funding for the first 2 years of DSRIP. We're now shifting. Obviously, that's going to become or has become more core now, but during the first couple of years to kind of give context and perspective how we did. So when we look at foundational transformational programs that are really going to impact and make things happen to change the way the Medicaid population and the behaviors of the Medicaid population and the providers that provide the services for that, you can see down the left-hand column kind of 5 major types of bucketed initiatives that we're really focused on as a PPS. Now, ED Care Triage is an actual project, but it's also a larger initiative that we're continuing around being able to hit the performance measures from here through the end of DSRIP, which is March 2020, around primary care access, hospital utilization reduction, and behavioral health metrics. And we feel like that particular initiative will help us in those areas. Interact, which is an initiative, once again, a project, and then an initiative around the skilled nursing facilities, and that population will really help us largely around hospital utilization reduction. The health home navigators, which is huge, around the metrics you see there in the right-hand column as well. A medical neighborhood, which is something that we have in our master participation agreements, for those providers in our network that are really going to be heavy in terms of the behavioral health metrics. And then the non-utilizer program is also huge for us. And we're looking to have efforts and resources and dollars going towards the programs and the initiatives on the left in order to see and earn our dollars and drive transformation on the right-hand column. So when we look at the improvement initiatives moving, you know, when you look at, like I said, we're in district year 3, measurement year 4, you can see that 70% of our incentive, 70% of incentive dollars are now tied to measurable performance and outcomes. Very little of our dollars is around actual hitting, you know, checking the box, so to speak. Performance deliverables focus on high dollar, high impact type measurables. You can see those in the bullets in the goal second bar there. A lot of focus around hospital utilization. What we're doing is we're promoting with community-based organizations to connect with these larger networks, because the social determinants of health impact the hospitalization utilization metrics, and we're making those connections with the efforts and the initiatives we're working on, which we'll be able to address later on in the program. In the light green bar, you can see the high performance metrics, which are more at risk and really begins to take the region to a value-based payment type mindset. And what we're doing is a virtual VBP type efforts around our clinically integrated network across the region. So that's a big deal. And then the right-hand block has to do, when we talk about high impact, high volume providers can earn additional dollars to help us meet our metrics. So that's how we're working. So in summary, when you look at, once again, rear view mirror, measurement year 2, we earn nearly 100% of all of our funding during that time. We're a leader in the state around potentially preventable readmissions. There's a lot of work to be done around potentially preventable emergency room visits. That is our biggest heavy lift, which needs a lot of effort. And then early measurement year 3 indicators show, and we've got data now that brings us state data through February of 2017, shows that we're on a better track than we were in measurement year 2. I'll change it back over and have Amy come back up.
Thanks, Al. So a little bit about our attributed population that we work with. A third are young people, accessible through pediatric practices, and 2% are 65 years or older. That makes sense. Most people are on primary Medicare at that point. 24% are fee-for-service, meaning they're not affiliated necessarily with a managed care organization yet, and about 75%, 76% are with Medicaid managed care, which means they're eligible for like a value-based payment contract or potentially a longer-term sort of negotiation strategy with the managed care organizations. 70% have a managed care assigned PCP. Those of us who work with this population know that often people are auto-assigned a PCP, and this can be a challenge when you're connecting on the primary care. And I think those of us who work in community-based organizations as well as like the hospital systems sort of feel this a lot, because people, you say, "Who's your PCP?" and they say, "I don't know," and you look it up and it's someone they've never heard of before. So I think this is definitely something that can be a challenge for our patients that we work with. And if that PCP is not convenient, they're going to go to an ED as a default. So that kind of is another piece of challenging work to get people to focus their wellness activities on a relationship with a primary care physician. And then 2% enrolled in health home. We can do better with enrolling people in health home, and I think health home is such a great model. We definitely know that the regulatory environment around health home can be challenging around people's ability to refuse getting engaged in the health home, and we have great folks who are working in health home and have really sensitive approaches to working with these patients and are trying to find the best way to communicate what the health home is so they better understand how it can help them. So I'll say again what we said. You're going to hear a recurring theme, which is the shift from really structured projects and really what was in the original implementation plans to more enhancing those projects and adding additional effort and initiatives that focus on health outcomes. So it's not that we abandon projects, but I think you're going to see enhancements in projects that, again, allow us to focus on health outcomes. We again, as I said, we had 72 total metrics. I'm sure Al has a similar load. And these metrics are really measured in 3 ways. So when we look at the metrics we want to try to affect, we have to look at really what's feasible and appropriate for us to affect. So things like measures that are affected by claims data, medical records review, and patient surveys, of the ones we know we can affect, the claims data ones are the ones we get the most closely to real-time data from New York State on. The medical record review metrics can be challenging because they're often sample sets that are looked at, so those can be challenging to affect. And then the CAP survey, which measures a lot of patient satisfaction and other sorts of sort of education initiatives that providers might do with their patients, those are definitely challenging to affect as well. But when you look at the metrics you're trying to affect, you need to understand how they're collected and the challenges and the opportunities that the collection method may offer you. And in measurement 2, we had 14 measures that met our measurement year 2 improvement targets, which is significant, almost 20%. However, it's important to note for our PPS, we had 26 measures, almost 40%, that had no improvement target. So we weren't able to actually close a gap to goal, which I think is an important to understand, like how far the state is kind of behind measuring these metrics as well. So we're in our 3rd DSRIP year. However, baselining for some of this stuff, we didn't even have a baseline for measurement year 2, and they will continue to say whatever we achieve and measure in measurement year 2 will become our baseline for measurement year 3, which they are now collecting, but we are in measurement year 4. I know, it's very confusing. But we don't have, you don't have a baseline, so we're using measurement year 2 as the baseline instead of measurement year 0 for some of these. We had 32 measures that did not meet improvement targets. This is not surprising. When you look at the load of the work, when you look at primary care specifically or hospital specifically, you have to focus your metrics. So there are going to be metrics that we're just going to have to say, we're okay with not meeting them, because you really have to kind of weigh the pros and cons of trying to pursue certain metrics. And that's a tough conversation to have, because you may potentially be leaving money on the table if you do that. But also I think you have to prioritize your work, and you have to say, with the resources we have, what can we really focus on? So equity programs is non-waiver funds, and those are sort of what I think you call your non-core programming funds. We have additional metrics on top of the 71, additional metrics that we focus on as well for the equity program, and we get separate payment for that. It is a large revenue stream for us. It's a larger revenue stream for us than Millennium, actually. And of the 6, 2 were met, 1 had no target, and 3 were unmet. But know that that's additional revenue stream for us, and it is an additional focus. Direction. So this is a similar slide to what Al showed you, so you can see the revenue that did come into the PPS. So we're roughly at almost 100% for year 1 and almost 97% for year 2. And I think, again, I'll show you the non-waiver, which is the bottom slide there. That's a huge amount of revenue for us. It's much more than, say a Millennium would be getting for this program. It accounts for almost 40% of our budget. And those are tied to a separate set of measures and a separate set of they're inside our 71 metrics, but they're separately measured and separately weighted and paid out. Those are directly coming from the managed care organizations as well. They don't come from New York State, those payments. So this is a snapshot. We always like to show this. So this is where we were at the end of June, where we were. And I guess one of the things we like to show is how much money is going out the door into what provider categories. So this tells you a little bit about 75% of the funds that we have received have been paid out. And again, we like to say that as much as possible, we try to get the money out the door to the folks so they can affect their projects and health outcomes measures as quickly as possible. Just one call out on the community-based organizations. This is a little bit of a categorization challenge, because community-based organizations was pretty wide open category for New York State to define. So we do have one of our larger independent practice associations counted in there. So that's a little artificially inflated, but we do have some really great community-based organization partnerships there. So we now are focusing on a smaller subset of priority health outcome metrics. Again, a lot of them are going to dovetail with our projects, and some are going to be crossing over multiple projects. A good example of that would be, say, potentially preventable readmissions or potentially preventable ED utilization. Those cross over multiple projects. We have 5 provider categories that are going to be the focus of pay-for-performance programs. That includes OBGYN, pediatric, primary care. That doesn't surprise anyone that you really do focus on the primary care networks to hit these metrics. We are paying out incentive dollars for rapid cycle evaluation planning and performance to an agreed upon plan. Our behavioral health partners right now, you're going to hear a lot about, Phyllis is going to talk to you a lot about our program for this. It is our behavioral health partners are kind of the first in line to be doing this, and I think they're going to be excited to participate in the program. The dollars are based on past performance, and there's actually an incentive payment to produce the plan and then perform to the plan. And we seek to support those metrics that New York State Department of Health sees as critical for their statewide performance as well. That also could create additional dollar opportunities for the PPS and the partners. And then longer term, we'll be working with Managed Care and Millennium to identify common Medicaid metrics region-wide, and that's going to be a challenge as well. Everybody has their own sort of favorite pet metrics. So I'm going to hand it off to Andrea, and Andrea is going to talk a little bit about what she's doing with Millennium and how we're working together, and then also Phyllis is going to come up. But I think, John, are you going to do the introduction?
A little bit, yeah.
Okay.
Yeah. I wish you could see your faces. That's like, it's a lot of information. The good news is there's no quiz. The other good news is these slides will be available on at least 3 websites. So the Population Health website, Community Partners website, and the Millennium website. So a lot of detail, a lot of numbers. If you really want to take a deeper dive, there will be an opportunity to do that. It's, what's the metaphor? Drinking through a fire hose, right? It's just so much information coming at you so quickly. So we realize that, so there will be opportunities to follow up. Couple real quick while we're taking a little bit of a segue. If you have questions that you've written down on your cards, please hold them up real high and we'll let people come around and collect those. So Amy and Al are coming back for the last section on the Q&A. So if you do have questions for Amy and Al, get your cards up now and we'll collect those so that we can hold them accountable. We do want to shift to the behavioral health issue too, because this is important. This is something that's come up repeatedly at these forums, and one of the things that, whatever the numbers are, something like 85% of the costs for Medicaid go to 15% of the population, and that 15% of the population, by and large, has mental health issues. So in terms of a kind of a risk stratification and finding, the best places to generate some savings for Medicaid and some improved services is in the mental health area, and this has come up repeatedly, so we decided to carve out some specific time for Andrea Wannett and Phyllis Gunning from Millennium Collaborative Care and Community Partners, respectively. So I will turn it over to you two. Thanks.
Okay. A little shorter here. Good morning. Good morning. So my name's Andrea Wannett, and I'm the Director of Behavioral Health at Millennium Collaborative Care. And thank you for coming out this morning. About a year ago, LaTanya, can you wave, LaTanya? Thank you. LaTanya and I are a big team of 2 at Millennium, behavioral health team. And we were looking at our projects, and we were looking at all these metrics that keep being brought up. With Millennium, we have 54 metrics we're focusing on, and we realized, oh great, 14 of them, 25%, all fall under behavioral health. So we said, we better get going on these. We had our 3 projects that we had been working on since the beginning. The 3 projects, just to remind you, if you aren't aware, there were 3 projects that fall under behavioral health. Behavioral health and primary care integration is the first one. Community crisis stabilization is the second. And the third was more of a prevention program focusing on access in the schools, trying to provide substance abuse prevention and mental health program in the schools and communities. So that's where we really focus the first couple years, or the first 2 years. Why isn't this moving? Oh, there we go. Okay, good. So after we looked at these 14 metrics, we thought, you know what? We better get our partners together to strategize how we can affect these metrics. So I'm very competitive, just as competitive as the next person. So of course I'm thinking, oh, we got to knock this out of the park. We need to get these numbers moving. But let's keep in mind the ultimate goal sure, we want to move that needle. We want to get more money, bring it back out to the community. But the goal is for that health of our community, the health of those we serve. So let's just keep that in the back of our minds. So what we did was we took what data we had, and as you've heard, that data is outdated. We took the best data we had. We looked at the high volume geographic areas. So for Millennium, those high volume areas are Erie, Niagara, and Cattaraugus counties. So we first of all focused with a work group in Erie County. Our largest hospital provider we pulled to the table, the behavioral health component from ECMC, those partners, the discharge planners, we brought to the table. We invited our outpatient clinic providers from our Erie County partners. They came to the table. We did the same thing about a month later in Niagara Falls, so about December of last year. And then recently in Olean, about 2 months ago, we started a similar process. So what we did was, once we built up this group in each of those 3 identified areas, we started to pull in some of those more I don't say outliers because we're all working together, but some of those stakeholders that weren't at the maybe first or second meetings. So that's where we brought in the MCOs, the health homes, et cetera. So that in primary care. So that's where you see those extra people being added. So in terms of our strategy, what we did, I told you we got the data that we could get that was the most recent. It's from the Department of Health MAP dashboard. So we grabbed that data, we looked at those 14 metrics, we presented those metrics and where we stood as Millennium, we presented those to the group. And then we kind of brainstormed, we said, well, which ones do we think we really need to work on? Which ones can we affect? So we brainstormed those potential wins, and of course, we researched those best practices. So just to keep it in perspective, those metrics, they're not just made up. There's groups across the state that come up with these metrics because they look at the best practices. They look at what can we do to help our population achieve the overall better health. So, you know, we're not just pulling them nilly-willy. We worked on these best practices as a group, we researched, and then once again, pulling in those collaborative entities depending on what we chose. There we go. So the areas that were selected were, I like to say they fell into 2 main areas. The first one was the follow-up after mental health hospitalization. There's actually 2 metrics underneath that, that grouping. One is, did the person who was hospitalized for that mental health issue, did they get an appointment with an outpatient mental health clinician within 7 days after their discharge? The second piece of that, did they get, if they missed that 7-day follow-up, did they then get an appointment within 30 days? So those are 2 separate metrics. If you hit, say Andrea was, I was admitted into a hospital, I had a mental health issue, did I follow up within 7 days? Maybe I had an appointment within 7 days, but maybe I missed it. I couldn't get childcare, I couldn't get a ride there, whatever the reason. So then, did that provider and or the hospital follow up with me to make sure I got in within 30 days? So the research shows if I am engaged with that outpatient clinic provider within a closer time frame, I'm going to be engaged in my treatment. And therefore, I'm going to be healthier, and tie back to what Alan and Amy were saying, I'm going to be less likely to visit that ED again. Okay, so that makes sense. So we focused on those. We also focused on the group of chronic disease management for people or patients with schizophrenia disorder. So as you can imagine, there's certain reasons why folks with the diagnosis of schizophrenia and or bipolar, actually for this metric, why they may be more likely to have comorbid health conditions. They could have heart disease, they could have diabetes. These things can be tied to their medications, but it also, as you may think, can be tied to their way of life. And if you're not thinking straight, you can't pull your thoughts together, it's not going to be a priority to take care of your physical health when mentally you're not feeling well. So we focused on that grouping as well. In terms of our strategy, this is one of my favorite slides because I'm a visual person. So what we did in our work groups, we gave everybody, sticky notes and we brainstormed. We really wanted to know out-of-the-box ideas. What are things that you've wanted to do for a long time, but yet you just didn't do it. You didn't think you had the resources. So we brainstormed those ideas. We broke it down into those 3 areas when we were brainstorming: the care management or communication and area, transitions of care, technology, and connectivity. Then what we did was we prioritized those high impact and low effort items. We wanted those quick wins. We wanted to be able to feel good with some of the progress and with some of the items or action items that we came up with. So what we did was we developed at least 2 action plans for each focus area. We were very clear what needs to be done, by whom, by what date. And we assigned people. We gave people homework, which I don't know, they probably didn't like. I know Michelle Curto from Horizon thinks that she works for me now, but she doesn't. There's her boss right there, Ann. But so we got very close and worked on some of these strategies. Here's some ideas that came out and some strategies that came out of that first grouping, that first area, the follow-up after mental health hospitalization. We had work plans to develop and identify relationship managers. Now you might look at that and think, oh yeah, that's so easy, Andrea. It does. It's an easy thing on paper. The thing is, you need to get everybody together. So for some groups that we pulled together, this was the first time that hospital discharge team had met some of my outpatient clinic providers. So it was building that rapport and coming up with some form of communication. For ECMC, it was the creation of a certain email address that all the discharge planners could get access to. So the outpatient clinics would know, okay, if I want to contact ECMC about any client, I'm going to email that universal email address, and they're going to know, what's going on. So that opening those lines of communication. We also helped to create an open access brochure with open access hours. So all of our partners agreed to have open access hours. Once again, it sounds pretty simple, but when you're trying to pull everybody together, for different reasons, people can or cannot do some of these things based on how they're set up. So we pulled the whole group together and moved it in that direction. Another area that was lacking that we ended up working on in the action plans is providing education about health homes. We saw on the slide 2%, I think Amy said, 5% are signing of eligible folks are signing up for health homes. Why? Well, people don't understand it. Even our own staff in the behavioral health clinics or in the hospitals might not have had a way to describe health homes in an effective way to really recruit people in. We also added some of our best practice research to adopt this motivational interviewing model called the Genesee model. All of our outpatient clinics have adopted or modified their intake process to really pull folks in to those first appointments. So they're motivating folks to come in the doors and to seek that treatment. We also educated partners on all those metrics. So 14 metrics, there's a lot of detail that goes into understanding those metrics. We also educated physicians on the topic, increasing that communication among the providers. And this is one of the first things we did. I should have probably put that at the top. But we did a survey to assess why patients don't follow up. So that was the first step. Here we are brainstorming all these great ideas. And then a couple minutes in, somebody raised their hand and said, hey, don't you think we should know why these patients aren't showing up? So using our group around the table, we sent out some surveys, we did face-to-face interviews, and we found out some of the main reasons why people aren't following up. And I'll tell you the top two. One of the top ones is transportation, and the second one this one was interesting, because I don't need to. I feel good. So someone's inpatient, And once they're released, they're feeling good at that time. So I don't need to show up within 7 days. I don't need to go to whatever appointment that they say I should go to. So what the discharge planners changed at the hospital was their conversation. Another simple strategy. What's that conversation that you're going to have before they leave, ensuring that the patient understands the importance of following up within a certain time frame so that they can understand and start to develop a work plan, a personal work plan to keep them out of the hospital in the future. In terms of our second focus area, oops, I skipped right over that fast. Sorry. There we go. Second focus area, chronic disease management. Our work plans were, I have to say for this area, it was a little more personalized. We came up with some generic kind of strategies, but from there, depending on the outpatient clinic or the hospital, they kind of veered off left or right for various reasons. So basically, I'll kind of touch on that a little bit more, but the generic things that we talked about was educating partners on the metrics, educating the physicians, creating that communications piece. But some folks were able to get a phlebotomist into their office. Some people were making sure that that appointment was happening and they were linking with that primary care. And some, I could think of one hospital who actually hired and trained a phlebotomist in their office. And now a new strategy, since some of our partners have become certified community behavioral health organizations or centers, they have now trained their nurses and wrote it into the job descriptions that they need to do some of these blood screenings and monitoring for those patients. And one last thing that we did was we began using the Office of Mental Health Psyches data, which shows the metrics, and had our partners really look at what patients need some of these screenings, who falls into, that denominator, which means who is eligible, who should we be treating. And we used HealthyLink as well. So in terms of our ongoing collaboration with Community Partners of Western New York, I probably should have said this from the beginning. Throughout this process, Phyllis, Amy, other folks from CPWNY have been at the table. We have partners who overlap. We want to work together. We want to push the ball up the hill together. So we've been collaborating. So not only did we co-author two of our first projects together, and we've been working collaboratively, we also have shared some of the costs for the Just Tell One campaign and those prevention programs in the community and in the schools. We have shared partnerships not only in my meetings, but when CPWNY holds their meetings, myself or LaTanya or someone else from Millennium always attends so that we can make sure we're not duplicative, but we're rather working together. And we've also developed complementary strategies for funding. So that's really kind of an overview of Millennium. And now, in terms of next steps, we're going to continue with those metrics, collaborate with other partners, continue to engage those MCOs, and focus on the psyches data. And I'm going to pass it off to Phyllis. There you go. Thanks. That one right there.
Yep. Hi. Well, welcome everybody, and I'm Phyllis Gunning, the Director of Clinical Programs at Community Partners of Western New York, and I think I'll start to tell you just a little bit about where we've been to date, the activity we've done, just as Andrea talked about, and then kind of where we're going and how we're doing that collaboratively with Millennium. Our approach has been a little bit different in District Year 1 through 3. We have worked with our partners here, many of those who are here, to set up some of those innovative projects. So with the behavioral health and primary care integration project, we've worked to get those shored up and lay the foundation for what we're going to be doing going forward. So Model 1 is integrating behavioral health into primary care. Horizon and Spectrum have been two of our main partners. We're also working with Niagara County Department of Mental Health. And we have counselors located at two of our high-volume Medicaid clinics, and also 6 primary care practices in Erie County and Niagara County. And so what we're seeing, and we've appreciated our partners who have that expertise, who've worked with us to say, we have a proposal. We can bring somebody in and work alongside your providers to figure out this integration and work out the bumps and to see where we can highlight some of the successes that can come from this kind of integration. So. Essentially, they're referred by a provider in a clinical setting. They conduct a behavioral health assessment and do a warm handoff to outside services if needed. We've seen some significant outcomes already. That conversation and having a behavioral health subject matter expert in the primary care setting has really shown some great successes. So having a higher show rate, 80% show rate when they've had that warm handoff from the primary care to the behavioral health counselor, who kind of has that communication with the patient and gives them really sort of an education of what is this about, and can kind of help sort out those things that could be confusing to somebody who might otherwise get a referral to behavioral health care, but they might not be ready to follow up if they have to navigate the system by themselves. So we've seen an 80% versus generally a 40% show rate if they were referred from the provider or from the community to navigate the system on their own. We also see the patients are more motivated to continue with their treatment, so that longevity, and they're again more educated to do that, and also this. The multidisciplinary team approach, where the behavioral health consultant is seen as a subject matter expert. So the providers are very pleased to have someone they can talk to, because they have had those patients in their care that maybe they've tried to approach it from a physical health approach, but really there are underlying behavioral health concerns that need to be addressed. So they are really very value that relationship with a behavioral health provider. Of course, we're looking for sustainability and working on these projects. So one of the barriers we've seen to having a behavioral health counselor and be able to bill in our Article 28 hospital-based clinics is our regulatory barriers. So we are working very closely with OMH and CMS to navigate application approval for co-locating an Article 28 and Article 31 services, which is the behavioral health services. This requires, many of you probably know the regulations, requires a change in the physical structure of the clinics, and we're ready to do that. We hope that we can see that move forward soon. Model 2 is having primary care in the behavioral health setting. We are very excited to we were very excited to have had a proposal from Endeavor, formerly Mid-Erie, and Inspired Health come to us and say, we really want to be able to build this from the ground up. So this came together as the Hope Treatment and Counseling Center on Southwestern Boulevard in the South Towns, and this is a holistic approach, fully integrated behavioral health and primary care setting. It's again collaboration between the behavioral health provider and the primary care. They provide medication-assisted therapy for both mental health and addiction. That's also available. So really, they're coming for a period of time to the Hope Center and are referred by providers. They are also then referred back to their primary care provider for ongoing care after their time with the Hope Center. Is this there? Oop, see, double. Okay. A few other interesting, innovative projects. Community health workers. So with Catholic Charities, that we've worked with Catholic Charities who have 3 community health workers embedded with Monsignor Carr. And they've been working very closely with their clinics around the region to really affect the follow-up after hospitalization for mental health, as well as improving access to care, reducing clinic no-show rates. That was something that they had seen in their organization. They really wanted to impact that. And so the community health workers are out in the community. They're an extension outside of the clinic, and they are working with patients who might have been lost to follow-up previously. And the extensive work, we're going to be spotlighting that just as a quick promotion in our December PAC meeting. That these in seeing what the impact of that. It's time-intensive work. It requires a special person to be able to do this kind of work, who will go and reach out to patients and say, and also addressing those social determinants of health that might have kept them, transportation, finance, housing has been a big issue. So helping. Embedding with Catholic Charities, they also have those support services that have they've been able to refer to as well. So seeing great success there. We also are working with Best Self and Spectrum with mobile health clinics, where they have a multidisciplinary team working with patients who might not be able to come to a clinic. They're going out and seeing those patients at the point of care where they are at. They also work closely with health home care managers. Telemedicine is one of our projects with under community partners, and we're working with Endeavor to on a crisis intervention project where they're installing cameras at each of their clinics. And because it's access to a prescriber is limited, so this gives the ability for Endeavor to treat patients at the point, wherever they're at, and that a prescriber can provide that support to a patient, no matter where they are at one of their clinics. So this is a project that's just getting underway, where our priority metrics there are avoidable emergency room visits and medication management. Telepsychiatry, we are still exploring ways to deliver telepsychiatry, especially in the rural areas where there are shortages of providers. We've worked with our partners at Chautauqua County Health Network, CCHN, in trying to figure out a model that we can employ in Chautauqua County. We have primary care providers who are excited about this, who've tried to have behavioral health providers embedded in their clinics, but physically they just don't have the volume to sustain that. So how can we do this with telemedicine? But we have had some bumps in the road with regulatory and reimbursement models, but we're still continuing to work toward, we're going to get there. We just really feel, by gum, we're going to get there. So working with the Department of Health as well and OMH on ways that we can work within the regulations or our restrictions, but to find ways that are sustainable. So District Year 3-4, where are we going from here? We took a good deeper dive on the measures, our successes and challenges from measurement year 1 and 2, as Al and Amy have talked about, and we took a look at where can we best focus our dollars and our energies going forward. So the two main big areas that we are focusing with behavioral health are access to preventative care. We did meet two of our adult access measures and came very close to our third, to the adult 65 and over population. But we want to maintain those gains and push that forward for next year. As you'll see on the right in the grid, that our measurement year targets still need to be met. So we want to sustain those gains and push those forward. Also, depression screening and medication management. We still have some work to do with medication management, antidepressant medication management. So again, we want to see where are we, and how can we push those red, pink numbers over into, translate those into green. So. And again, this kind of shows where our collaboration with Millennium has been. So we've worked with Andrea and LaTanya and the folks here. So we've been part of the Millennium work groups, as Andrea talked about, the hospitalization, follow-up, schizophrenia. And so we really felt that we could position ourselves is in, and to support our behavioral health partners in a region, is through access to primary care and the depression measurements. So we are working with our behavioral health partners to connect to one area we've seen is that a gap between behavioral health and primary care communication, and outside of these integration models that we've had, how do we support our partners in connecting the dots with the primary care? So what's different? So we're moving from those. We have that foundation of those projects that are in place, and now we're stepping on the gas, and we're moving to performance-based. Our key outcomes, systematic identification of and tracking of primary care providers. So of those who have a primary care provider, how is your organization tracking? And we're seeing that some of the systems may even have limitations. They don't even have a mechanism to track those patients. So how can we support you in getting your systems ready? This will be especially key in moving to value-based payment arrangements. We want to support those linkages between behavioral health and primary care. And then for those who don't have a primary care provider, how do you connect those patients? This is very key. So the other piece is getting that communication back to your primary care provider. How are you exchanging information? So the measurement, this is on an incentive, really in an a rapid cycle evaluation approach. To develop an action plan, how you're going to do it, measure your baseline, set improvement targets, and then the payment structure will be based on your quarterly reporting and your ability to meet those targets. Heavy finger. So lastly, just the other piece that we've collaborated very, very closely was with the Just Tell one, and you've probably seen the ads and the Facebook pages and all of that. So it went live October 31st last year. It has seen incredible success, and some of these results here, they reached over 1 million Facebook visits in a year, so extremely exciting. And so this is really a social media platform that has been carefully put together and with collaboration. And phase 1 has continued. Now they're moving into phase 2, which adds a component of 24-hour 7-day-a-week chat capability, and then integrating with the Genesee County YMCA helpline, they'll be able to have skilled listeners in place who can refer them to resources throughout the county, the regions.